ჩვენ გავაგრძელებთ მოხსენებას. ჩვენი შემდეგი მომხსენებელი გახავთ პროფესორი მაიკლ როდენი, ექიმი ენდოკრინოლოგი, ექიმი დიაბეტოლოგი, დიუსელდორფის ჰენრიხ ჰაინეს უნივერსიტეტის პროფესორი, დიუსელდორფის საუნივერსიტეტო კლინიკის ენდოკრინოლოგიისა და მეტაბოლოგიის განყოფილების დირექტორი, დიუსელდორფიდან ძალიან ცნობილი პროფესორი დიაბეტოლოგიაში, ექსპერტი, რომლისთვისაც მისი ინტერესების სფეროს წარმოადგენს ერთ-ერთი ინტერესების სფეროს დიაბეტი და ღვიძლი და შესაბამისად იგი წაიკითხავს ლექციას ღვიძლის გაცხიმოვნების კლინიკური ასპექტების შესახებ დიაბეტის დროს. Dear Professor Roden, could you hear me?
Yes, do you hear me?
Yes, thank you. Hello. Nice to see you, and thank you so much for joining us today on our meeting. I'm sorry for being late, and hope it's not a big discomfort for you. And we can start. You can share your presentation.
So thank you, Nadia, for the kind invitation and introduction. I hope you can see my slides.
Yes, we can.
Look so. So I will try to make up some time by speaking a little bit faster. We will be discussing about clinical aspects on non-alcoholic fatty liver disease in the context of diabetes. First of all, Nadia has introduced my work place, which is in Düsseldorf, which probably not all of you know, which is the capital of the largest state in Germany, North Rhine-Westphalia. And my work is based in the German Diabetes Center, DDZ, which has more than 200 employees. And of course, it is a center that concentrates on diabetes research, from basic research to public health aspects. And we also have the clinics for endocrinology and diabetology in Düsseldorf at the university. And we are currently building a new research building called Cardiac, where we will focus on the network between cardiac and diabetes research, which has been just funded by about 75 million euros. And this will further boost our research. So why are we interested in type 2 diabetes in Germany? I think our general concept that holds true worldwide is that it is the overnutrition, and during the last, or at the end of the last talk, you already discussed about different kinds of diets. And I fully agree with Professor Landsberg that it is indeed the excessive amount of energy intake which drives obesity, insulin resistance, dyslipidemia, and finally type 2 diabetes. But there's also physical inactivity, and particularly abnormalities in muscle metabolism and mitochondrial function, which are responsible for burning the excess of energy, and of course, abnormal energy storage in a dysfunctional adipose tissue. And this also explains the rapid increase in diabetes over the last 50, 60 years, because in the 1950s, the prevalence of diabetes in Germany was less than 1%, and now it's about 10%. And that means that currently in Germany, about 8 million people suffer from diabetes. And it is so that Germany is in the top 10 of the prevalence of the diabetes worldwide. And it is also one of the countries that has a higher prevalence of non-alcoholic fatty liver disease, because, and we will be talking about this later on, there is a tight relationship between diabetes, obesity, and non-alcoholic fatty liver disease. Overall, the prevalence of this fatty liver disease not related to alcohol or hepatitis is about 25%. In Asia, it's 27%, in Europe, 23%, and in Africa, that's the only continent where it's much lower, less than 15%. So what is non-alcoholic fatty liver disease? In general, several terms are not used perfectly well, or inadequate, or simply wrong. The definition of NAFLD and the several, let's say, subtypes of this disease complex have been defined by the European Associations for Liver Disease, Diabetes and Obesity some years ago and published in 2016. And this picture just shows how to correctly use the terms. The head of all of these disorders is the non-alcoholic fatty liver disease complex. And this summarizes non-alcoholic fatty liver or steatosis, NASH or steatohepatitis, which does not require to have fibrosis, but it requires the presence of inflammatory state in the liver tissue. With an increase of fibrosis, and there are 4 grades of fibrosis, F0 to F4, the fibrotic state might end up in cirrhosis. And when this is decompensated, then finally you need to go for transplantation or intensive treatment. And of course, at any stage of the disease, the risk for hepatocellular carcinoma and then transplantation is higher compared to people without fatty liver disease. In addition, and we will be talking about this later, even in early stages of non-alcoholic fatty liver disease, there is a higher risk for cardiovascular disease and also diabetes-related kidney and nerve disorders, nephropathy and neuropathy. But coming back to the very basic definition, what is a fatty liver disease? A fatty liver disease is if your liver contains more than 5% of fat by histology, or more than 5.56 or so percent by using a non-invasive imaging technology. In this case, it's proton magnetic resonance spectroscopy, but the same holds true for the more frequently used PDFF, which is based on magnetic resonance imaging. It further requires the absence of significant alcohol intake and the absence of any other relevant or known liver disease. So it's kind of an exclusion diagnosis, and it is very important to keep in mind the current recommendations and current limits. So the point is that when we say at a certain amount or above a certain threshold, we talk about alcoholic or non-alcoholic fatty liver disease, that this does not necessarily mean that we recommend to use the maximum amount of alcohol just before this limit. But just to go for these recommendations and limits, the recommended alcohol limits, so not more, not recommended to use the alcohol, but if you do it, you should not have more than 14 units of alcohol, which is 6 pints or pints of beer, 7 glasses of wine, depending on the alcoholic strength and the volume, and 14 single shots of spirits. And this is the more strict version. There is a more relaxed version that would allow up to 21 standard units, but only for men, which is based on the different sensitivity of the alcohol dehydrogenase and the capacity to metabolize alcohol, where men are favorably having a higher capacity compared to most women. So now coming back to the mutual interaction and risk of fatty liver disease and type 2 diabetes. In general, people with type 2 diabetes have an up to 5-fold higher risk, even if you adjust for the age, to develop or to have non-alcoholic fatty liver disease. That ends up that about 70 to 80% of people with diabetes finally have fatty liver disease. We will be talking later about differences between the percentage of fatty liver disease in diabetes at beginning of the disease, at onset of diabetes. And of course, the presence of diabetes markedly increases the risk of progression of fatty liver disease to fibrosis and cirrhosis. On the other hand, type 2 diabetes also increases the mortality in people with the mortality of fatty liver disease related causes, but also for cardiovascular related death, as well as the diabetes related death. So it is also the presence of NAFLD, which is a markedly enhancer of morbidity and mortality. And then on the other hand, There are people that have non-alcoholic fatty liver disease, particularly those with more progressed disease, which don't have diabetes, but are at a doubled risk to develop diabetes during the course of the disease. So on one side, people with diabetes, obesity have a high risk for fatty liver disease, but also those with non-alcoholic fatty liver disease have a higher risk for diabetes. Actually, that also holds true for fatty liver disease based on alcohol and hepatitis, particularly hepatitis B and C, seem to have a higher risk for diabetes incidence. So coming back to the possible causes and interactions and mechanisms, I don't want to go into much of cellular details, but this is a nice kind of way to explain it based on a simple study that we performed a few years ago, 2 studies actually. And the first study, we just gave a palm oil emulsion to healthy young humans at the dose that corresponds to a typical US style or Italian style fast food. And that ended up in a rapid reduction of insulin sensitivity, or in other words, an increase in insulin resistance by 15 up to 34% in the liver, the muscle, and in the adipose tissue. And that corresponds then to a higher amount of fat stored in the liver, about 35% higher fat compared to a state without palm oil ingestion, an increase in energy metabolites such as ATP, reflecting higher energy activity or mitochondrial activity, and also evidence for early inflammatory signs. This we could not show in humans, but in a parallel study in mice. And also the gluconeogenesis increased markedly by 70%, so that there was a minor increase also in glucose. There was also more storage of fat in the skeletal muscle, and also an abnormal reaction of the adipose tissue to fat, ending up in a lower ability to keep the fat in the fat cells. And that leads to increase of fatty acids, which per se then are shuttled back to the liver, where they can be stored as triglycerides, but they can also interact with insulin signaling in the liver and in the muscle. Interestingly, and that is a little bit going back to questions on different kinds of diets, we then compared this saturated fat one meal diet, so it's not really a chronic diet, it's just the effect of one single meal, with a single fat emulsion containing monounsaturated fats predominantly. And we found more or less also the induction of insulin resistance. However, with the monounsaturated fat, or let's say something which corresponds to more Mediterranean style diet, these people were protected from accumulating fat at least after 1 dose. So take-home message, overload of fat, at least from these studies, would suggest that it would induce insulin resistance, but a more unsaturated fat diet would prevent more from developing fatty liver disease. Second point to pathogenesis, and I mentioned that already in the previous slide, is so not talking about nutrition, but about long-term disbalance between energy intake and energy expenditure will lead to adipose tissue dysfunction. The basis is still not fully understood, but one can imagine that once the adipose tissue enlarges, there can be mechanistic causes. There can be also hypoxia. There can be a pressure on vasculature, lower perfusion. All of that has demonstrated in several experimental models, but nobody could tell what is the real initial cause. However, once the adipose tissue is enlarged, then macrophages infiltrate the adipose tissue, cause insulin resistance, and thereby cause release of adipokines. Most of them are related to inflammatory pathways and end up in other tissues. Some of them end up in the brain and modulate appetite. And also the impaired insulin action in the adipose tissue increases lipolysis, releases non-esterified fatty acids, as well as glycerols, and they shuttle back to the liver, where they can be either stored as triglycerides, synthesized to lipotoxic signals, which cause insulin resistance, or can modulate gluconeogenesis. Be aware that fatty acids cannot be a direct substrate of gluconeogenesis, but they can allosterically stimulate enzymes that accelerate gluconeogenic mechanisms. And on the other hand, glycerol, of course, is a substrate for gluconeogenesis. Okay, so these can be the key points how fatty liver disease can develop in the context of obesity and type 2 diabetes. I now want to come back very shortly to differences between people with diabetes. And this is based on recent papers, originally a paper from Lund University from Emma Alquist and Life Group, who came up with the concept of subtypes or clusters of diabetes. And we have used this clustering in our German diabetes study, GDS, which comprehensively phenotypes people at the onset of diabetes, or correctly speaking, during the first year after diagnosis. And we also used this clustering and identified based on HbA1c, antibodies, age, BMI, and HOMA indices, four subtypes of type 2 diabetes along to the type 1 diabetes, which is now called the severe autoimmune diabetes. The important part is that these subtypes have different features, also with regard to liver fat content, and particularly shown here in the green bar, the severe insulin resistant diabetes subtype, as it says, which is the subtype which has the highest HOMA IR values, also has the highest value of liver fat at diagnosis. You can see that also other subtypes of type 2 diabetes, particularly also the obesity related, but also the age related and the insulin deficient subtypes, are with their mean values above the threshold of fatty liver, but they are only marginally above this threshold. It is important that also this severe insulin resistant subtype has the highest marker for hepatic fibrosis, and that further increases over the first 5 years upon diagnosis. And it's also the same subtype that has a higher risk for not only presence of nephropathy, early signs of nephropathy at beginning of disease, but also progression of nephropathy. And we further, and that's just an addition to that, analyzed that the gene which has a very high risk for developing fatty liver disease and fibrosis is particularly enriched. It's particularly enriched in the CC and the GC genotype in people with the severe insulin resistant diabetes and the increased fatty liver, meaning that there's also a gene and environment interaction for developing fatty liver disease. And interestingly, this is also a group where this genotype associates more with adipose tissue insulin resistance, which again would support the concept of the adipose tissue as an important driver of non-alcoholic fatty liver disease. This means that at the beginning of diabetes, there's a different risk of different subtypes for fatty liver disease, which increases the importance to identify these severe insulin resistant subtypes. But I should also mention that over time, all the other subtypes also develop or have a higher risk than the non-diabetic population to develop fatty liver disease. So this can probably in the future be of relevance when we do this kind of prognostic and subclassification tests, which on the long run might help for a precision prevention of diabetes and fatty liver disease, particularly for the insulin resistant and obesity related diabetes subtypes. And maybe in the future, this will also have important implications for a more targeted or precise treatment of diabetic patients. But this is actually not the topic of my talk. I should come back here and say that, as I mentioned already for the insulin resistant subtype, but it holds true for the general type 2 population, that there is an increased risk for cardiovascular disease. There's an ongoing discussion if there is an independent risk of fatty liver disease for cardiovascular disease, or if it's mediated by obesity or diabetes or whatsoever. This is still unclear, but in any case, a more progressed fatty liver disease has a more than doubled risk for developing cardiovascular disease. There's also an increased risk for chronic kidney disease, and the hazard ratio is about 1.4. And this is interestingly independent of age, sex, obesity, hypertension, diabetes, and other conventional nephropathy risk factors. So in this case, there indeed seems to be an independent association between kidney and liver disease. And finally, there's also an increased risk for neuropathy, both peripheral neuropathy as well as cardiac autonomic neuropathy. And this has been extensively studied by Professor Dan Ziegler in our group in the German diabetes study, where he found that the more fat you have in the liver, the more abnormalities can you find in testing for cardiac autonomic neuropathy. And that is probably also clinically interesting because people with fatty liver disease have a higher risk of sudden death, which is sometimes associated with cardiovascular disease, but could be very well also be explained by cardiac autonomic neuropathy. So now coming back for the last part of my talk to screening for non-alcoholic fatty liver disease. There is a still ongoing discussion on how and whom and how frequently we should screen for fatty liver disease. And honestly speaking, there is no final consensus what is the optimal strategy. And this is also a moving target because currently a number of non-invasive tests are developed and validated, as well as also non-invasive imaging techniques are more frequently used. And so that there will be a high dynamics in the future for fatty liver screening. What I show you here is at least the accepted basis from the European guidelines. So you should not screen the whole population, but you should screen all those who have a per se higher risk for fatty liver disease, which is obesity, type 2 diabetes, so-called metabolic syndrome, as well as a number of endocrine diseases listed here, such as hypothyroidism, hypopituitarism, hypogonadism, and also, for example, surgeries such as pancreatoduodenal resection. In these people, you should perform ultrasound and liver enzymes. And if steatosis is absent, liver enzymes are normal, then a follow-up within 3 to 5 years is just fine and could be just by repeating ultrasound and liver enzymes. If steatosis is present, then you should be aware that the ultrasound is not very precise. So that if you detect steatosis, that steatosis is present, the amount of fat is already much higher than, for example, as I've shown you before in our early diabetes study, where they use high-end techniques, spectroscopy and imaging to measure quantitatively fat. Ultrasound is able to detect fat only if it's higher than, let's say, 15 to 20%. So you can be sure that if you see fat in the ultrasound, that there's really steatosis. There can be the option that you find normal liver enzymes, which per se do not exclude the progressive fatty liver disease. So you should go for serum fibrosis markers. Several of them are around. I will go a little bit into detail more later. And if there's a low risk from both liver enzymes and fibrosis markers, a follow-up in 2 years would be just fine. And then also, of course, repeat the fibrosis markers. If you find a medium to high risk for fibrosis markers, then this could be an indication for a specialist referral. And of course, if you find significantly abnormal liver enzymes, which is something like more than 2 to 3-fold above the respective normal upper limits, then a specialist referral should be mandatory, particularly for excluding other chronic liver diseases, a more in-depth assessment of disease severity, and finally, of course, to take the decision to perform liver biopsy or not. So what about diagnostic tests? When we published our guidelines, and I was there responsible for the European Diabetes Association 5 years ago, most of the tests here shown have not been sufficiently validated, and most of them are now quite well validated. But as I said, this is still a moving target. But at present, what can be recommended, at least for as an indirect marker of fibrosis, is the so-called FIB4, because it is quite sensitive, and if you take care to use the right limits for normal or for abnormal, then based on the parameters age, AST, a platelet count, and ALT, so liver enzymes, age, and platelets, you have a nice, easy to use parameter to assess risk of fibrosis. And the current accepted value is 2.67. Above this value, the risk for fibrosis is much higher compared to those before. Between 1.3 and 2.7, you cannot be sure, and you probably should repeat it or use other assays or tests to go for excluding or diagnosing fibrosis or NASH. Imaging-based technology can nowadays not only measure liver fat, but also using FibroScan, or in other words, transient elastography, allows you to have a nice indicator of fibrosis. And given on the kilopascal values, you can even have a rough estimate of the fibrosis stage of fibrosis grade. And everything above 7.5 kilopascal should raise the awareness for fibrosis. There's also NMR-based techniques for elastography, but they are not so frequently used because they are very expensive and limited to institutions which have such a magnet. For example, we have both the elastography on ultrasound and MR basis, and we have to say both perform quite well. Probably the MR is a little bit better. And this information can now be used for sequential testing. And that has been shown, for example, by the group of my friend Gianluca Persegin in this paper by Giadulo and co-workers, where they used first plasma AST, and with a higher value of 26 units per liter, they then used the FIB4. And then if the FIB4, they used a quite low threshold of 0.87, then they made the indication to perform liver biopsy. And by this means, you can at least have a more narrow, or let's say a smaller group that needs to be sent to an expert hepatologist or to be discussed for liver biopsies. Nevertheless, and I don't want to go into details here, but this is a very nice paper by Professor Cusi and colleagues just showing that still at present, particularly in people with type 2 diabetes, both the non-invasive tests for NASH as well as fibrosis are not so good as one would expect, and that simply measuring ALT and AST is not so bad when compared to FIB4, ProCR, and other assays. So now, for the last minutes, let's talk a little bit about prevention, or particularly treatment. And this is a very nice table, or figure, which you can frequently see from Dr. Villar-Gomez and colleagues, who just found that when they treat people for 52 weeks, for 1 year, with lifestyle intervention in a rather small cohort of less than 300 people, they can achieve complete resolution of steatosis. When you just go for a 10% of weight loss. But even with a 5% of weight loss, you already get something like a 65% of improvement of steatosis. But not only fatty liver, but also NASH and fibrosis regression and resolution can be achieved. So if you can achieve over 1 year a 10% weight loss, then you can almost completely get rid of the fatty liver problem. The only point which is disappointing is shown here in the last line. And those who listened to Peter Landsberg's talk just before, he mentioned that what can be seen by all of us, that only 10% of the people treated under these conditions achieve the 10% weight loss consequently and consistently over the course of 1 year. So that is the problem, and that is also the main issue why we need to have also drugs for treatment, particularly with the progressive non-alcoholic fatty liver disease. And as most of these people have type 2 diabetes, currently we mostly focus on drugs that we use in type 2 diabetes, and that can also be used in fatty liver disease, simply because there is no official treatment of fatty liver disease per se, licensed or allowed by the authorities within Europe. But within the different drugs that we use for diabetes treatment, it is the GLP-1 receptor agonists, the PPAR gamma agonists, and the SGLT2 inhibitors, which show at least some effect on fatty liver disease. There's also one single study that shows that for one DPP-4 inhibitor, but that's a small study, and it's still not quite clear if this will also hold true for all of these substances in the group. I should only mention here that metformin biguanides, which are used to improve hepatic insulin sensitivity, they have no effect. Metformin has no effect on non-alcoholic fatty liver disease. But there is some epidemiological evidence that people on metformin have a better outcome for cirrhosis. If this is really a cause-effect, is still unclear, but we cannot recommend metformin for people with fatty liver disease at the moment to achieve a treatment effect. Very few words to the key studies that have shown positive effects. That is pioglitazone in 2 studies, the PIVENS trial and a later trial in type 2 diabetic patients. In general, to cut a long story short, pioglitazone improves insulin sensitivity, markedly improves hepatic steatosis. It has a specific effect also in inflammation, but not on fibrosis. And on top of that, you might be aware of several side effects and limitations of use with pioglitazone, so that we only use it for a limited number of patients, carefully looking for side effects and using the contraindications. The other group is the SGLT2 inhibitors, and now we have already 4 studies where these different compounds have been used in randomized controlled studies. And interestingly, all of them showed a decrease in liver fat in absolute terms of 2 to 5%. Most of that was related to the decrease in body weight. But in one study that we actually did by Sabine Kahl and colleagues, we found that the 3.5% absolute change in liver fat was independent of any effects on weight loss, because there was no weight loss. And that also corresponded to a relative change of liver fat by 34%. And that is the study briefly described: 24 weeks, empagliflozin 25 milligrams once daily compared to placebo. And what we find is that there is a marked decrease in liver fat content compared to placebo, which is probably due to the increased glucosuria and the lower amount of energy for the liver. But what we also found was that there was an increase in adiponectin, which means that there was an increase or an improvement of adipose tissue function. And that could be mediated by the lower uric acid in the circulation during treatment with empagliflozin, which releases the inflammatory stress and oxidative stress in the adipose tissue. If this really is an important factor for understanding the effects of empagliflozin on liver metabolism is unclear and needs further testing. The most important study at the moment is the lean trial using liraglutide in people with NASH and with and without type 2 diabetes. And with liraglutide, they could actually achieve a significant improvement of the resolution of non-alcoholic steatohepatitis. There was a borderline improvement of inflammation when they measured in the histology, the hepatocyte ballooning score, but there was no improvement of fibrosis. So a little bit similar to the treatment effects of pioglitazone, improvement of steatosis, inflammation, but not of fibrosis. And a similar study has been just published by Phil Newsom and colleagues, again a phase 2 trial, in this case with semaglutide for 72 weeks given in people with and without diabetes. 62% had type 2 diabetes. And what they found is that there was also an improvement of resolution of NASH without worsening of fibrosis with the higher dose of 0.4 milligrams of semaglutide compared to placebo, not seen with the lower doses. And again, the right panel here shows you no significant difference with regard to fibrosis. And on top of that, we of course have to be aware that there are also adverse events which were more frequent in the semaglutide group compared to the control. Okay, that brings me already to the end of my story. I will not have time to go into details on future treatments, simply because a number of different compounds have been tested, and actually the majority of them have tested negative and showed no improvement. But there is still ongoing studies with particularly obeticholic acid, to a certain extent with elafibranor, and also with FGF21 active compounds, which seem to have certain effects. And we are still looking specifically for drugs that are improving also the late stage of the disease, which means fibrosis. So probably the best compounds would be to have the early treatment, diet, maybe anti-hyperglycemic drugs, probably the new double agonists such as tirzepatide, or also what needs to be acknowledged, people with marked obesity would also benefit from bariatric surgery. And then combine this, let's say, lifestyle plus diabetes related treatments in the early course together with antifibrotic agents which are currently developed to prevent the long-term progression of disease. With this, I would like to thank all our study participants, my cooperators involved in our several studies, and of course, many thanks to you for listening, and I'm now ready to take a few questions.
Thank you so much for an excellent presentation and very interesting information you presented today. Thank you for being with us, Professor Rodeni. It is a great honor for us to have you with us in our meeting. And now I will jump to questions. There are questions in Georgian. I will read in Georgian and the translator will translate you into English. Hamart იღაშვილის შეკითხვა არის ჰეპატოზების დროს რომელ სტატინს ენიჭება უპირატესობა და რა დოზით იწყება მკურნალობა?
So unfortunately, I did not hear the translator. Can you repeat it in English to me briefly? Hello?
Professor Rhodeni, do you hear the translator?
I did not hear the translator. So could you briefly repeat in English?
Yes, of course. There is a question regarding the hepatosis. Which statins are preferable in patients with hepatosis, and which dose is best?
Okay, that's a good question. So statins can be used in people with steatosis, with fatty liver disease. We should be aware that, and there has been a quite recent meta-analysis on side effects of statins. Statins have a higher risk for increase in transaminases and hepatic side effects. So among the different, except for the muscle symptoms, among the other side effects on the liver have the rather highest risk. It's still very low, but here's the higher risk. And there seems to be a dose-dependent risk for atorvastatin, okay? So based on these findings, I would say you should use statins in people with fatty liver disease. The more progressive disease, the more careful you need to be, particularly in fibrotic states. And you should monitor liver enzymes more closely in people with fatty liver disease when they are on statins. Once they are quite stable, then you can use the usual frequency, but at the beginning of statin treatment in people with steatosis, I would be careful and first do the measurements after, let's say, 6 to 8 weeks, and then probably 3 months, and check if the liver values are stable. If they increase, you definitely need to stop treatment with statins. I have to say that statins also have a beneficial effect on fatty liver disease. They can actually slightly reduce liver fat. On the other hand, they, as you know, increase the risk of type 2 diabetes in some, but not all analyses.
Mm-hmm. Okay, next question. Just Natia, I'm asking translator, could you speak just to see if Professor Rhodeni hears you?
Yes, now I can hear you.
Great. So I will read question in Georgian and yeah. ნატია ოსეფაშვილის შეკითხვა არის COVID გადატანილ პაციენტებში რამდენიმე შემთხვევა მქონდა ჰიპერტრიგლიცერიდემიისა და პრედიაბეტის, რას გვეტყვით თქვენი გამოცდილებიდან ამ კავშირზე და გამოსავალზე? მადლობაო.
Okay. Honestly, we don't have a lot of experience with the patients with hypertriglyceridemia after COVID. I think this is particularly, most likely, this results from effects on the liver, most likely. And in this case, the treatment should be, what I would say is, if the treatment is excessive, then of course you need to lower the triglycerides. If there's a moderate increase in triglycerides, we would not care about it. So it's just about if you really increase risk of pancreatitis above 1,000 triglycerides or so, then this is important to address. Otherwise, I would not take a major therapeutic decision and rather wait.
Okay, thank you. Next question.
Unless there's one point I should mention. If these are patients with diabetes insufficiently controlled, then of course the first step is to improve the diabetes control. So if you have a patient with hypertriglyceridemia and an HbA1c of 9, you need to correct the HbA1c down to, I don't know, 7.5 or 7, and then you will see that the triglyceridemia will decrease by 50%. That I should see. But if you have a patient with the near normal HbA1c perfectly controlled and the triglycerides are 300 or 400, then I would rather wait and see if there's an increase of if there are symptoms of pancreatitis. Then of course you need to do a treatment where you would give, for example, insulin, which is the best to lower triglycerides.
Okay, there was a question about the vaccination of patients with diabetes. Could this patients with diabetes be vaccinated without first be consulted by endocrinologists or any doctor? Do they need any previous investigations before being vaccinated?
So you talk about the COVID vaccination.
COVID vaccination.
Okay. So in general, the risk of a patient with diabetes without complications of COVID is the same as for a non-diabetic patient. Patients with progressive diabetes would definitely have a worse outcome of their diabetes. So if we're talking about type 2 diabetes, you know, from my point of view, it is not mandatory that a patient is seen by a diabetologist. It is maybe different if we talk about type 1 diabetes. So there is some evidence or suggestions, most of that is not firm, that people with autoimmune disease might have more problems after vaccination. And so, for example, in this case, I think a contact with an endocrinologist or diabetologist is useful, particularly for people who have a multi-autoimmune disease, so morbus Addison's disease, type 1 diabetes, thyroid disease. For these patients, probably one needs to take an informed decision and also clarify with the patient possible risks and outcomes.
Well, thank you. Next question is in English. I will directly read the question. Thank you all for excellent speech. What we can consider as a main pathologic factor in normal weight young people with NAFLD and without diabetes? And except the dietary intervention, can we consider any oral drug in order to stop progression of steatosis?
So the question is, what's about the patient who is lean and has a fatty liver disease?
Yeah.
This is, of course, let's say, I would not say rare, but it's the less frequent situation. And we do not fully understand the pathogenesis. I think what is very important in these cases to rule out any other liver disease. So these patients should be definitely seen by a hepatologist or someone who is really an expert in ruling out any liver disease. So we're talking about autoimmune hepatitis, biliary cirrhosis. We're talking about rare storage diseases, which might come apparent in adult age. We might think about, of course, Wilson's disease. It's rare, but it can be there, and it's not enough to simply measure copper or whatsoever. So that needs a thorough workup. Then, if all of that is negative, some of these lean people still have abnormal visceral fat content, and that brings me to the most important, what we need to make sure to exclude, which is lipodystrophia. Okay, so lipodystrophy can be either due to HIV treatment acquired, but also as a genetic disease which might come apparent later in life. So these people, some of them appear already early in childhood, but some of them, partial lipodystrophies, become only apparent in adult age, and they are quite difficult to diagnose. So you need to carefully monitor fat distribution in the body, and so on. But if you have a patient who has less amount of subcutaneous adipose tissue, which you can assess, and maybe also has some kind of genetic background, these people always or almost always have fatty liver disease and impair lean or almost lean. Okay. So that is the most important. And yeah, what about treatment? In the case of lipodystrophy, it depends on the cause. The very rare causes, which are due to leptin abnormalities, leptin resistance or whatsoever, can be treated with leptin nowadays subcutaneously. And otherwise, also, this is one of the few indications where insulin sensitizers have their highest value. So you can use pioglitazone in these patients, which would help to redistribute fat if possible and decrease liver fat content.
Mm-hmm. Thanks. And which dose would you prefer in these cases? 30?
For pioglitazone, I think pioglitazone, I'm not sure what you have available. 15, 30, and 45 is the usual one. So my experience, so we used pioglitazone also previously. In Germany nowadays, we almost have given up using pioglitazone because the authorities don't like it and don't reimburse it only in rare cases. So, but I think 30 milligrams would be fine. But if you have a patient with lipodystrophy, then probably 45 milligrams are the right way to go. And of course, monitor side effects, osteoporosis, water retention. Don't give it to people with myocardial failure or before testing echocardiography and looking for a decent ejection fraction.
Mm-hmm. შემდეგი შეკითხვა, უბრალოდ თამარ ფაღალ შეკითხვა მინდა გავაჭრა, რომელიც დაისვა და ვფიქრობ, რომ პროფესორ როდენთან უფრო მეტად იქნება რეალური, რომ ეს კითხვა დავსვათ. კოვიდის დროს აღმოჩენილი დიაბეტის მართვას და ჩვეულებრივ პირობებში აღმოჩენილი დიაბეტის მართვას შორის რა განსხვავებაა და რამდენად მიზანშეწონილად მიგაჩნიათ დიაბეტით დაავადებულ პაციენტებში COVID ინფექციისას კორტიკოსტეროიდების გამოყენება.
Okay. Yeah. So I think we had such a question already before with Dr. Landsberg. Personally, if there is a patient with diabetes, a type 2 diabetic patient, and this patient has a very mild COVID infection, then the patient could actually keep the medication, could even keep the metformin or SGLT2 inhibitors. Of course, there is the drug that is best tolerated, but also less effective is DPP4 inhibitors. But if the course is very mild or at the beginning of the disease, the patient could more or less keep the medication he or she has. Once such a patient needs to be hospitalized, then very rapidly we need to reconsider the medication, and in most cases we would switch to insulin, also because many of these patients, and that's part of the second question, would receive glucocorticoids. And for this, I cannot give you a recipe, so we do it really on an individual basis. I'm not sure how it's working for you, but even in our university hospital, it always depends who is in charge and how frequently the diabetologist is called, you know. So we try to be involved as close as possible and adapt the dose simply based on the actual glucose levels. So it's really a pragmatic way, but I would say the take-home message is type 2 diabetic patient with COVID move to insulin rather early than late.
Okay. There is a question. I will within Georgian. Kapitan Ketevani katis შეკითხვა არის, რა გართულებები შეიძლება იყოს აუტოიმუნური თირეოიდიტის შემთხვევაში ვაქცინაციისას? ანუ COVID-ის ვაქცინა იგულისხმება და რა რეკომენდაციას ვაძლევთ ამ შემთხვევაში? არ ვიცი მართებულია თუ არა ეს შეკითხვა, მაგრამ პასუხში გაიჟღერაო. მადლობ თომ.
I probably understood the translator, but not the first acoustically, not the first part. So what?
So the question is, with the autoimmune Hashimoto thyroiditis, if the COVID vaccination needs any specific consideration.
No, I think the point is you need to clarify with the patient who has a multi-autoimmune disease that there might be a higher risk for complications or insufficient response or whatsoever. So you need to talk with the patient about that. But in general, we would also recommend to vaccinate these people. And to my knowledge, but I do not know exactly, there is no current specific recommendation for people with Hashimoto or other autoimmune diseases.
Okay, great. And the next question is in English. So thank you very much for interesting presentation. According to your data, AST or alanine aspartate aminotransferase more than 26 was used for screening of NAFLD. Is this value considered as really high? And second question concerning the metformin, do you still recommend it in type 2 diabetes with high insulin resistance?
Question one, I think I mentioned it, but I'm willing to repeat that because it's important. Still, for the transaminases, each lab has its own normal values or upper lipids of the normal range. It depends on the enzyme assays, and some have a normal upper normal limit, something like about 20, others 40 or 50. Okay, so this is why I showed this experiment from that lab, but this is not valid for all the labs. This is why I say you need to look for a 2 to 3-fold increase above the upper limit of your specific lab. So if you have something like 40 or 50, then I would definitely think about more intensive screening if the AST, ALT is, let's say, 80, okay? Particularly in people with diabetes, because I mentioned people with type 2 diabetes might have rather low transaminases despite progressive liver disease, okay? Second part of the question, you know, still in clinical practice, we don't measure insulin resistance. I'm not sure if you do it. We don't do it. I do it in the private practice for special patients who want to do it, want to have this measurement. But in general, we do not really still take care. But if I would assess a patient as an insulin resistant patient, then of course metformin still to me is the first choice, no problem, because it improves insulin resistance. But having said this, people with insulin resistance also have high fat in the liver. So probably this will shift in the future more and more towards SGLT2 as the first oral agent, and for subcutaneous effects and more or improved weight loss for GLP-1 receptor agonists. But still, this is a question of costs of the local systems. And even in Germany, which is considered to be quite rich, they would not allow to have a GLP-1 receptor agonist as a first-line treatment. Although it might be best for the obese, fatty liver patient, but that's not what we can do.
Yeah, but in a private practice, if the patient could afford it, so you would prefer GLP-1 receptor agonist for obese patients with metabolic syndrome and fatty liver?
Yeah, so in the private practice, I would discuss with the patient If this patient is really obese, has a fatty liver, seems to be quite insulin resistant, then I would say, we can start with a simple oral medication, or be aware that with metformin, you might lose 1 to 3 kilograms or so, with SGLT2, 2 to 4 kilograms or so, and with a GLP-1 receptor agonist, you might lose more than 4 kilograms, particularly with the newer ones. So it depends on that, and then I would explain the side effects, and then it depends. So I think the patient, if the patient can pay for that and has the right to choose, then we should have the discussion with the patient.
Yeah, I absolutely agree. And let me see, there are no more questions. So no more questions. Thank you so much for your time, for being with us. It is once again great honor for us and great pleasure to see you again, Professor Röden.
It would be nicer to be present in Georgia personally than
Next
just on the screen.
Next time, I hope that we can host you here in Tbilisi. Thank you once again. Bye.